Well, good morning to everyone at COOS who couldn't be here in person. We miss you, but I figured I'd try to involve you a little bit with a presentation of my case here. My name is Mike Jennings. I'm a fourth-year med student up at the University of Kansas. I worked on this interesting case of fungal keratitis with my mentor, Dr. Miles Greenwald. Excited to share it with you. So we have a 50-year-old male. He has no significant past medical history and no eye surgeries. Of note, he is a contact lens wearer. He presents to our clinic for 2 weeks of left eye pain. He had previously been seen in an outside clinic and started on moxifloxacin drops, and then presented to us after about 3 days on those. On presentation, you can see the defect we have here on the cornea. So it's both an ulcer with an underlying infiltrate. His vision here pinholed to about 2150 in the left eye, but pressures look good and the rest of his exam was relatively benign. He did note some mild symptomatic improvement on the antibiotic drops he was on, so we decided to go ahead and continue the drops and just add in atropine daily. Of course, we got cultures of the wound just to see if we could elicit any growth from that. Day 3, we had no growth, but we did see worsening of the infiltrate. So we went ahead and switched him to fortified antibiotics of vancomycin and tobramycin every 2 hours. And then day 6, his vision decreased a hand motion in the left eye, and we did get a positive culture result for Fusarium fungus. So we decided to go ahead and start him on natamycin every 2 hours, which kind of on this side of the poster, there's a trial that I've noted. It's called the MUT1 trial. It shows that natamycin drops are superior to voriconazole drops. So that's kind of the decision making there. And then through days 10 and 17, we kind of just kept seeing him, kept noticing that it was getting worse and worse. We started on oral antifungals on day 10. And then day 17, you can see here, we have a pretty significant hypopyon developing. The infiltrate is approaching closer to the limbus. And so at this point, we kind of decided that we needed to go for urgent PKP on him. And thankfully, everything turned out well during the procedure. We injected some intrastromal voriconazole on the inferior border of his cornea, kind of where the infiltrate was approaching most closely. And then this picture down below is post-op month 7 for him. He is doing well. He's now actually seeing not 2400, but we saw him this week in clinic and he's at 2060. And so we have no evidence of graft rejection and no evidence of reinfection. He's doing well. So kind of take-home points for this. For him, the post-op course involves a week break from steroid drops, so you don't want to allow any type of reinfection to incur. But then kind of the flip side is we want to be sure that we're not rejecting the graft. So after a week, we started on steroid drops. And then at 3 weeks, we started him on oral prednisone. And then he remained on his topical natamycin and his oral voriconazole for even longer thereafter. But yeah, thank you for joining in and listening to this case presentation.